Good afternoon and welcome everyone to today's webinar, Preventing Candida auris Infections. This session is brought to you by Project Firstline Rhode Island under the Center for Acute Infectious Disease and Epidemiology at the Rhode Island Department of Health in partnership with the CDC. I'd like to thank you all for taking time out of your busy day to join me today. And I also want to thank you all for your dedication and care that you deliver to our community in your healthcare role. Before I introduce myself, I'd like to direct your attention to the chat box to find the link to our pre-session survey. This pre-session survey must be completed at this time if you would like CNE, CE, or certificate of training for this session. So please take a moment to fill this out if you haven't already. And for those of you who do not know me, my name is Lisa Ledoux. I'm an infection prevention training liaison for Project Firstline Rhode Island. I've been a nurse for over 30 years, and my professional experiences have been in many different healthcare settings. Even though my nursing roles and responsibilities have varied, infection control and prevention have always been in the forefront of my nursing practice. At this time, I'd like to introduce Dr. Kearney to come on camera.
Hi, everyone. Thanks for being here. Looking forward to an exciting session.
Thanks, Dr. Kearney. And at this time, please take a moment to introduce yourselves in the chat. Tell us where you're from. And it's great to have you all joining me again. And I also want to introduce Abby Anderson, who is our Project Firstline Rhode Island project assistant. Abby will be posting information for you throughout the webinar via chat. And the Project Firstline team is behind the scenes in support of this webinar today. Here are the continuing education criteria for those of you who are attending and would like to review CNE credit for today's webinar. This is a 60-minute session that's approved for one contact hour by the Northeast Multi-State Division Education Unit, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. The Northeast Multi-State Division Education Unit, in order for you to receive your CNE credit, the following steps must be completed. Step 1, if you haven't already done so, you want to complete that pre-session survey. Step 2, you're here, you're attending the training with me today, so glad to have you all here. In step 3, you must complete the post-session survey, and the post-session survey will be emailed to you tomorrow. You must complete the post-session quiz, which there will be a link to that quiz that will also be emailed to you tomorrow. For other healthcare colleagues here today who are opting for certificates of training, EMS continuing ed, and dental IPC continuing education, steps 1 through 3 are required. So step 4, taking the quiz, is strictly optional. So again, thank you for joining me, and we will discuss Candida auris and what you can do as healthcare professionals to help stop the spread of this fungus that acts like a bacteria. Proper PPE and diligent cleaning can help prevent the spread of C. auris. This emerging fungal infection often spreads in hospitals and nursing home settings and can cause serious infections. Healthcare professionals are commonly the transient vector of Candida auris. And a vector is a carrier of a germ from an infected individual to a non-infected individual. This means healthcare staff transiently get C. auris on their hands or clothing, and then they move from room to room, caring for and touching many patients and using shared medical equipment among their patients or residents. Today, we will review how you can prevent the spread of this fungus. In order for you to stop the spread, it's important to learn more about Candida auris and have an understanding of the following. What is Candida auris? Why is it a concern? What patients are at risk for Candida auris? What are the symptoms? How does it spread? And what infection prevention actions can you take as healthcare workers to stop it from spreading? Here's our agenda for today's session. We just did our welcome and introductions. We will go over the learning objectives. And there are a few keywords and definitions I'm going to review that you'll hear me use throughout today's training. We'll define Candida auris and how it has impacted healthcare and discuss why it's such a problem. Review some infection prevention and control measures. And then I'm going to present 3 clinical case scenarios, and let's see if you are prepared to care for a patient diagnosed with Candida auris. We'll then wrap up with key takeaways, announcements, end of session feedback, and Q&A. The learning objectives. After the session, the learner is going to be able to define a multi-drug resistant organism, MDRO, and understand their impact on healthcare. Understand what Candida auris is and learn about its emergence in the healthcare setting. Identify the pathways for Candida auris, and then apply control actions in healthcare settings to prevent the spread of Candida auris. So here are some of the words that I mentioned that you're going to hear me use frequently during the session. I thought it'd be good to just do a quick review on the acronym and the definition of these common words. First, colonization. Colonization is defined as a presence of germs on or in a person's body, and they're alive and growing. People can be colonized with germs without symptoms of any infection. And colonization can increase a person's risk for infection. Also, people who are colonized can unknowingly spread these germs to others through person-to-person contact or contaminated surfaces in shared settings. Some people are at even higher risk for infection when they are colonized. And these include patients who are critically ill in an acute care setting or others who have compromised immune systems. Primarily, colonization occurs on the skin, but other body sites can be colonized. And there are no current strategies how to decolonize. The second term is healthcare-associated infections, HAIs. They're infections that patients get while receiving treatment for medical or surgical conditions. HAIs occur in all settings of care, including hospitals, surgery centers, ambulatory cares, dental offices, long-term care facilities, such as nursing homes and rehab facilities. Some patients are at greater risk than others, such as young children, the elderly, and people with compromised immune systems. Other risk factors are long hospital stays, or the use of indwelling catheters, medical equipment, failure of healthcare workers to wash their hands, and overuse of antibiotics. Sometimes HAIs are caused by antimicrobial resistant pathogens, making them difficult to treat. And our last key word is multi-drug resistant organisms, MDROs. They are bacteria or fungi that are resistant to one or more classes of antimicrobial or antifungal agents. These agents can no longer be used to control or kill a bacteria. They can cause serious infections, and they spread easily between hospitalized and nursing home patients. They can be found in the bloodstream, lungs, urinary tract, wounds, skin, and surgical sites. So before we discuss and get into Candida auris, I want to go over how does antibiotic resistance happen? Antimicrobial resistance happens when germs like bacteria and fungi develop the ability to defeat the drugs that are designed to kill them. That means the germs are not killed and continue to grow. Resistant infections can be difficult and sometimes impossible to treat. There are lots of germs, and a few are resistant to antibiotics or antifungals. When antibiotics or antifungals kill bacteria that is causing illness, they're also killing good bacteria that protect our bodies from infection. The antibiotic-resistant bacteria then grow and take over. And some bacteria give their antibiotic resistance to other bacteria, causing even more problems. In the United States, approximately 35,000 people die from an antibiotic-resistant infection yearly. Okay, so what is Candida auris? Candida auris is an emerging, multi-drug resistant yeast that is highly transmissible, resulting in healthcare-associated infections or outbreaks, especially in long-term care facilities. Skin colonization with Candida auris allows spread and leads to invasive infections, including bloodstream infections. Candida auris, also referred to as C. auris, so you're going to hear me interchange both those words, Candida auris or C. auris. It's a fungus that can cause severe infections and spread easily among residents in nursing homes. It was first identified in 2009 in Japan, and the first culture was taken from drainage in the external ear. So in Latin, the term candida means yeast, and the term auris means ear. Hence the term Candida auris, a yeast that was cultured in drainage from the external ear. People who get invasive candida infections are often already sick from other medical conditions, so it can be difficult to know if you actually have C. auris. The most common symptoms of invasive candida infection are fever and chills that don't improve after antibiotic treatment for a suspected bacterial infection. Only a lab test can diagnose C. auris infection from a culture of blood or other body fluids. Here's a timeline of C. auris cases from when it was first identified in 2009. In this slide, clinical cases, it's the number of diagnosed cases of C. auris, and it's represented in the purple bar graph. Clinical cases identified are based on culture diagnostic testing from specimens collected during clinical care for the purpose of diagnosing or treating this disease. Clinical cases include both confirmed and probable. The screen number represented in the blue bar graph represents the number of patients found to be carrying C. auris on their bodies, even though they are not sick with infection. Screening is when swabs are collected from patients to determine whether they may be carrying the organism somewhere in their bodies without signs of active infection. So you can see over the years from 2013 how we've seen an increase in C. auris. And here is the Candida auris tracker. And some of you joining me here today know how much I love trackers and tracking data. This is a site where you can track Candida auris. The CDC has this tracking data on a website, and Abby will show the link in the chat for you if you'd like to check it out. There's a drop down in the upper left where you can set the time frame where you want to view the number of cases and screenings identified in the United States. I extracted the data from this tracker that I used on the previous slide from the bar graph. So it's pretty neat if you want to check that out. So why is Candida auris such a problem or concern? Well, first off, it's difficult to identify. C. auris is difficult to diagnose. It requires special testing, and it sometimes is mistaken for other infectious diseases. It can be misidentified as other types of fungus, unless specialized lab methods are used. And this misidentification can possibly lead to a patient getting the wrong treatment. You want to make sure your lab has the correct fungus identification method to identify C. auris. Correctly identifying C. auris is critical for starting measures to stop the spread and prevent outbreaks. Another concern is that it's very difficult to treat. C. auris and other drug-resistant organisms are sometimes referred to as superbugs. Superbugs is a term used to describe microorganisms that are resistant to most antibiotics commonly used today, and they're formed when antibiotics are used regularly and frequently. C. auris is often resistant to medications, and this makes it very difficult to treat when there are no medications that C. auris is not resistant to. Another concern is that it's persistent in the environment. C. auris can survive weeks on surfaces in the environment. It also can spread via asymptomatic colonization, able to cause prolonged colonization, possibly lifelong for some. And it also causes serious infections, particularly in hospital and nursing home patients, as I've mentioned, with serious medical conditions. More than 1 in 3 patients with invasive C. auris can lead to death when it is invasive in the blood, heart, or the brain. And lastly, C. auris can easily spread in hospitals and nursing homes, as I've mentioned. So just like other multi-drug resistant organisms that you may have heard or be familiar with, C. diff or MRSA or VRE, C. auris can be transmitted in healthcare settings and cause outbreaks in some facilities. The symptoms of Candida auris depend on the part of the body that's affected. In general, the symptoms include fever, chills, fatigue, body aches, low blood pressure, high heart rate, and low body temperature. C. auris can cause ear infections, wound infections, urinary tract infections, and infections in your blood that can spread to the rest of your body. Since most people who get Candida auris infections already have an underlying health condition, they have a much more increased risk of mortality. And it's important to remember that many people who are infected with C. auris do not develop any symptoms, which can make it difficult to detect and control the spread of this fungus. And as healthcare professionals, it's important to know which patients are at higher risk for C. auris infections or asymptomatic colonization. And these patients include advanced age, if that's the most common. However, C. auris infections have been found in all ages, from preterm to the elderly. Those who have received multiple healthcare and post-care facilities, such as nursing homes, or especially those on ventilator units. Patients who have presence of wounds, or presence of indwelling medical devices, such as IVs, PICC lines, feeding tubes, urinary catheters. These seem to be the patients at the highest risk of getting C. auris infections. And also patients recently who received antibiotics or antifungal medications, either for a prolonged period of time, or ones who have had recent surgery or invasive procedures, who have immunocompromised conditions, such as like diabetes or heart disease. So how does it spread? Candida auris can spread through touch via hands of healthcare professionals who have touched a contaminated patient, a surface, or a device. C. auris can persist on surfaces in all healthcare environments, so it could spread from person to person in any healthcare setting. This fungus can survive on surfaces for several weeks, making it easy to spread if proper infection control measures are not in place. C. auris has been identified on mobile or reusable equipment that is shared between patients, such as pulse oximeter glucometers, temperature probes, blood pressure cuffs, ultrasound machines, dental utensils. Close contact with patients who are colonized or who have Candida auris can develop asymptomatic colonization, which puts them at risk for invasive infections. And then these colonized patients can in turn serve as a source to spread to others. Another way Candida auris can spread is through clinical care. C. auris can enter the bloodstream through wounds or surgical procedures, or as I mentioned already, medical devices, your IVs, your feeding tubes, your ventilators, when that skin is broken down, allowing this fungus to enter the body via those open areas. So here's our first poll question, and I invite you all to participate. You can put your answers in the chat. How long can Candida auris survive on surfaces? A, minutes, B, hours, C, days, or D, weeks? I'll give you a little bit of time to put your answers in the chat. To answer the poll question. How long can Candida auris survive on surfaces? Let's see how everybody did here. And the answer, great, 57% of you said it weeks. As I mentioned, so it can survive on surfaces for weeks. Good job, and I appreciate you participating. So next, we're going to go on to some infection control measures that you can do to prevent the spread of Candida auris. We know that prevention is the best management. We're going to be reviewing identification, communication, and precautions. Before we move on, though, I want to briefly mention here a couple of other infection prevention measures that help to prevent the spread of C. auris. It's important to be aware of antibiotic stewardship. Antibiotic stewardship is the effort to improve how antibiotics are prescribed by clinicians and also how they're used by patients. Improving antibiotic prescribing and proper use of antibiotics is critical to effectively treat infections, protect patients from harm caused by unnecessary antibiotic use, and also combat antibiotic resistance. We want to ensure that people are only prescribed antibiotics when they have a definitive bacterial infection diagnosis. And another preventative measure is screening patients and visitors. If patients are also visitors that are visiting a healthcare facility, they may be screened for C. auris when there is a suspected outbreak in that facility. All right, so let's start with identification and learn why early identification of C. auris is so important. Rapid identification is key. However, as we mentioned, it can be quite challenging to identify. So swabbing axilla, which are your armpits, or swabbing the groin as soon as C. auris is suspected, and then sending it to the lab quickly is critical. The sooner you know, the sooner you isolate, then the sooner you communicate, and then the sooner you trace contacts if necessary. C. auris can be misidentified as other types of fungi. It is difficult to distinguish from other Candida species unless specialized lab technology is used. So again, check and see if your lab has the means to detect C. auris. The misidentification can lead to a patient receiving the wrong treatment and eventually cause more harm. Colonization can lead to the spread of Candida auris, right? Then cause invasive infections, which it may sometimes lead to death. Patients in healthcare facilities often remain colonized with C. auris for many months, perhaps indefinitely, even after an acute infection has been treated and resolved. Some common sites on the body where C. auris is colonized are skin. Skin is the most common site, but C. auris can also be found in the nose, ears, axilla, groin, vagina, the urinary tract, respiratory tracts, and in wounds. And as I mentioned earlier, currently there are no known strategies on how to decolonize. We know now that Candida auris can live on surfaces for weeks, right? We just did that poll question. C. auris has been cultured from multiple locations in patients' rooms, including both high-touch surfaces, such as bedside tables, bed rails, and also surfaces that are farther away from the patient, such as a windowsill. So in this image, you can see areas where C. auris can live and where it has been identified. It's able to survive on a wide range of dry or moist surfaces. In this hospital room image shows some common sites where C. auris was detected. And there are probably many others, but right now these are ones that are most popular, most common, I should say. High-touch surfaces such as bed rails, IV pump and pole, the faucet, the countertop, bedside table, vital sign equipment. And the most common area are the healthcare workers' hands, right, as I mentioned. So those are all some common sites where Candida auris has been found. So next we're going to move on to communication. It's very important to communicate the incident of Candida auris. Communication refers to a clear and effective communication between healthcare professionals, facilities, and different staff and departments within the facilities of a patient who has C. auris. So if transferring a patient from a long-term care skilled nursing facility to a hospital, you want to communicate to the receiving facility if the patient has formerly been identified having C. auris, or if there could be a potential that the patient may be colonized. You want to assure that that receiving facility, that the personnel there are aware of the risk and can take the proper precautions to prevent spread. Interfacility transfer communication is really, really important, as well as flagging the medical record. This will help to notify all in contact with an infected person. So by flagging in the electronic medical record, it will remain in that system. So let's say the patient gets discharged and then that patient has a readmission. This allows all personnel caring for this patient to have awareness when this patient does arrive at triage or they get transferred, from hospital to nursing home. Think about a transfer within a facility. Can you either cohort or place an infected patient in a private room? A private room is the best choice if possible. Cohorting is when two patients are placed in the same room and share the same infection. So if two patients are being cohorted or placed in a shared room with the same infection, this really should be discussed with the infection prevention and control personnel just to understand all potential risks. If patients are cohorted, PPE must be changed between the care of each patient. Facilities should identify residents at risk with wounds or indwelling medical devices and post clear signage outside of the patient's room indicating the type of PPE required and defining high-risk resident care activities. If there is a confirmed case of C. auris, prompt investigation should occur. You want to investigate the possible sources. Was there a roommate? How long was the patient in the facility? Where in the facility was your patient? Did the patient, come into the ER and go to the ICU, then go to a med surg floor, and then from there possibly went to the OR or went to radiology to get some testing done? So you really want to make sure you know where these patients have been, or did the patient come into the facility with a C. auris infection? Another communication that is key is having discussion with the patient's physician or care team. Assess the necessity of any invasive devices. Ask that provider, how long will the patient need to have, a G-tube or a PICC line? And always remember to include all necessary staff that comes into contact with the patient. You want to make sure that ancillary staff is aware that precautions need to be taken, such as case managers, dietary, clergy, and maintenance. So another infection prevention action is the use of standard precautions. Standard precautions are infection prevention practices that apply to all care activities, regardless of suspected or confirmed infection status. Standard precautions constitutes the primary strategy for the prevention of healthcare-associated infections, HAIs, among patients and healthcare personnel. So it's important to educate staff to adhere to hand hygiene, proper use of PPE, cleaning and disinfecting. And also standard precautions, use of standard precautions, and then you would use transmission-based precautions as your second tier when needed. So the first standard precaution we're going to discuss, and the most important, is hand hygiene. Hand hygiene is critical, especially with C. auris, because it is contact-based. Educate patients to clean their hands frequently and have awareness of surfaces touched within their room. Instruct family and visitors to clean their hands with alcohol-based hand sanitizer. Reinforce standard hand hygiene practices for all healthcare personnel. Alcohol-based hand sanitizer is the preferred hand hygiene method for C. auris when hands are not visibly soiled. If hands are visibly soiled, you will always wash with soap and water. And as always, a constant reminder is wearing gloves is not a substitute for hand hygiene. Use dedicated medical equipment and minimize the number of healthcare staff caring for a patient if possible. Ensure that adequate supplies such as the hand sanitizer, gowns and gloves, cleaning and disinfecting agents, make sure those are all available to implement and maintain appropriate infection control measures. Hand hygiene is very, very important. And maybe some of you in the audience may want to start a hand hygiene program in your unit. Set goals to improve compliance, conduct audits on all disciplines. And when you get the audits and get the data, it's important to share those results with the frontline staff and leadership, right? Because sharing all those results keeps everybody accountable. So when caring for patients with C. auris, healthcare personnel should follow proper hand hygiene practice. And here are 5 moments of hand washing with direct patient care. There are other moments when hand hygiene is critical, such as preparing a meal and eating, but these are the 5 moments that you should be proper hand washing before any patient care. So first, you want to perform hand hygiene before touching a patient, before you are about to perform a clean or aseptic technique, after body fluid exposure, after touching a patient, and after touching a patient's surroundings. Another standard precaution is PPE, proper use of PPE. Gowns and gloves should be available outside of each resident room. Proper donning and doffing, putting on PPE and taking off PPE is important to prevent the spread of infection. A trash can large enough to dispose of multiple gowns should be available for these rooms. How many times have you walked by and seen overflowing trash bins with dirty gowns? All staff and visitors want to be informed and prepared when entering a resident's room. They need to know what PPE should be used and when. And we're going to review in a few slides the different precautions to use, when to use them, and what PPE is recommended. So the last standard precaution to use to prevent C. auris infection is cleaning and disinfecting. All healthcare personnel providing patient care should be trained on which mobile and reusable equipment they are responsible for cleaning and how to clean the equipment properly. Some personnel are often unclear on who's responsible for cleaning the equipment and how it should be cleaned. Because equipment moves from room to room several times a day, in the case of vital sign monitors and glucometers, mobile or reusable equipment is likely the source for C. auris to spread. Also, make sure the appropriate disinfectants are being used for environmental cleaning. Ensure that EVS personnel are educated on how to look up the appropriate product against C. auris. Effective disinfection is critical. Cleaning and disinfecting is very important. It needs to be done daily, frequently, and properly. You never want to rush cleaning a terminal room or a common area where many people sit. You always still want to work very close with your EVS staff. High-touch surfaces such as bed rails, over the bed tables, doorknobs should be cleaned daily. Responsibilities for EVS versus nursing should be clearly defined in various healthcare settings. Ensure there's no cracks or tears in upholstery or mattresses. Also, avoid the use of tape on hard surfaces. I think we've come a long way with that. Everything was always taped up on the walls many years ago, but you can't really clean a surface effectively with tape in place. If terminal cleaning is required, the privacy curtains change should be done with all discharges. You want to use disposable equipment if possible, and try to avoid sharing medical equipment. But if medical equipment must be shared, thorough cleaning and disinfecting must be done between patients. You may be familiar in your facility if there's a process for cleaning shared equipment. For example, some facilities apply a clear plastic bag over an IV pump that signifies that pump and pole have been cleaned. Some facilities place stickers on equipment that's been, to let them know it's been cleaned. And some facilities have a clean or a dirty area that's designated for the equipment. So here's a question for you. I invite you to participate and put your answers in the chat. What does your facility do to ensure staff know that shared equipment has been properly cleaned and disinfected between patient use? So you want to share your answers. How do you know when you're working? How do you know what's been cleaned? Do you have a certain process where you are? Signage Okay, Tabitha, good. So we'll say if it's clean or dirty. Clean and dirty areas, yes, perfect. The dates of sterilization for instruments, yes. Good. So then you all have different processes depending on your place where you work. So as we know, Candida auris is difficult to kill on surfaces. Effective disinfecting is critical. So make sure you're using the appropriate disinfectant. We know C. auris can persist on surfaces for a long period of time, and many products are not effective against killing C. auris. So the disinfectant products from List P should be used for daily and terminal cleaning. In the next slide, we're going to go over what List P is, it's how to look it up. So here's an image from what the EPA, what it looks like. And Abby will show a link to this site. The CDC recommends use of an Environmental Protection Agency registered hospital grade disinfectant against C. auris. So this list was created. List P is specific for disinfectants effective against C. auris. The EPA has reviewed lab testing data demonstrating that these products do kill C. auris, and a product's effectiveness can change depending on how it's used. They can differ, have different directions for different pathogens. So you always want to make sure that the label directions are followed clearly, that they include contact time in order to be effective. So how do you check if a product is on List P? So again, there's a site you can go to. First, you find the EPA registration number on the product label. You look it up, the EPA reg number, followed by, it's got like 2 or 3 sets of numbers there. On the disinfectant list, search the registration number exactly as it appears on the label. And once you see the results on the disinfectant list, make sure to check that the product's label includes directions for use against Candida auris. Information about listed products is current as of date on this list, and inclusion on this list does not constitute or endorsement by the EPA. Okay, so we reviewed standard precautions, and what to use for standard precautions with C. auris to prevent the spread. The next level of precautions is transmission-based precautions. And transmission-based precautions are for patients who are known or suspected to be infected or colonized with infectious organisms, including certain organisms that require additional control measures to effectively prevent transmission. Since the infecting agent often is not known at the time of admission to a healthcare facility, transmission-based precautions are used. And these precautions are added measures for infection prevention strategies to prevent the spread of diseases. Okay, so let's start review and go over. We're going to start with our first transmission-based precaution. We'll start with contact precautions. So there we go. So contact precautions are intended to prevent the spread of infectious agents that spread by direct or indirect contact with the patient or the patient's environment. You're going to use contact precautions for patients with known or suspected infections that represent an increased risk for contact transmission. These precautions are used when patients have an infection that can be spread by contact with the patient's skin, including mucous membranes, feces, vomit, wound drainage, or other body fluids. Healthcare personnel are in the patient's environment or surroundings frequently that may be contaminated. So contact with the patient's surroundings, it may be overlooked as a means of how this infection can spread. A single patient room is preferred for patients who require contact precautions. And here's a signage some of you may be familiar with. I've seen it many times. If not, I'm just going to go through the steps really quickly. The steps are as follows. You're going to always clean your hands before entering a room, and also clean when leaving a room. Clean your hands when leaving. So again, cleaning your hands upon entry and upon exiting a room. You're going to put on gown and gloves before entering the room, and then discard gown and gloves before exiting the room. Do not wear the same gown and gloves for the care of more than one person, and use dedicated or disposable equipment. And clean and disinfect reusable equipment before use on another person. Next, enhanced barrier precautions. These are precautions used in long-term care facilities only. They are not used in acute care. Enhanced barrier precautions are recommended for residents known to be colonized or infected with an MDRO, as well as those at increased risk of acquiring an MDRO. And again, this includes residents with wounds or indwelling medical devices. Standard precautions still apply while using enhanced barrier precautions. So for example, if splashes and sprays are anticipated during high contact care activity, face protection should be used in addition to gown and gloves. Currently, residents in nursing homes require higher levels of care than they did in the past decades. These residents often need more hands-on and close contact. So most transmission of resistant organisms occurs during this type of close care. And the studies have shown that nearly 50% of nursing home residents have a resistant organism on or in their body that their caregivers are frequently unaware of in that case, right? So resident to resident pathogen transmission in skilled nursing facilities occur mostly from healthcare personnel who may unknowingly carry and spread MDROs on their hands or clothing during high contact care activities with patients or residents. Considering this, caregivers may not be using the appropriate precautions to protect themselves and other residents when performing care. This is why infection control prevention trainings are so important to keep clinical and non-clinical personnel aware and safe. Next, these images are a pocket guide the CDC created for staff. And Abby will show the link if you want to download and print to give to your staff or coworkers. It's a really good little pocket guide for staff to keep in their pockets there for reference during their shifts. So as a recap, enhanced barrier precautions are used for residents in long-term care facilities who have indwelling medical devices that put them at risk, such as central lines, urinary catheters, feeding tubes, tracheostomies, or ventilators. Also patients who have wounds, or patients colonized by an MDRO or infected with an MDRO. Okay, so that's when enhanced barrier precautions are used for residents. They're also, so it's going to be used also during the high contact care you're going to be giving your resident. In those high contact care activities include dressing, bathing and showering, transferring, providing hygiene, changing linens, changing briefs or assisting them with toileting, and caring for or using an indwelling medical device. So if you're emptying out a Foley catheter, and also if you're performing wound care. So before entering a patient's room with enhanced barrier precautions in place, you want to follow these steps. First, gather all needed supplies and materials. Next, clean your hands. Then correctly put on your gown and gloves. After care is done, you're going to throw away your gown and gloves in the trash bin. Then clean your hands again. You're going to complete all these steps before moving on to another resident. So here's our last poll question before we move on to our case scenarios. And here's the question. Enhanced barrier precautions are not used for patients in long-term care facilities, patients with indwelling medical devices, patients with MDROs, or patients in acute care. So again, if you want to fill out the poll question there, give you a little bit of time. So when enhanced barrier precautions are not used for. All right, let's see how everybody did. All right, great job. And I see some put answers in the chat, and then 73% of you said D, patients in acute care. Correct. We do not use enhanced barrier precautions in acute care settings. All right, excellent job. So now we're gonna move on, and we will be going over 3 case scenarios, and let's see how well you would do in the proper precautions you would use for caring for a patient with Candida auris. Okay, I'm going to read you a scenario, and then there'll be some questions and an opportunity for us to discuss. Okay, so it's your turn for an admission. You probably bet it might be close to change of shift, huh? Okay, so you're admitting a patient that is transferred to your skilled nursing facility from an acute care facility. She had a long stay in the ICU and was intubated. She arrives with a G-tube, and she completed IV antibiotic therapy treatment before arrival. So should this patient be put on precautions? Yes or no? You want to answer in the chat? Should this patient be put on precautions? You could put your answer in the chat, yes or no. Yeah, excellent, you guys. Good. All right. So looks like most of you answered yes. So let's see. Yes, this patient should be put on precautions. Great. So next question. What type of precautions and why? So if you want to put your answers in the chat on that one. So what type of precautions will we be using and why? Remember, we've got a patient that is, she was transferred to your skilled nursing facility, right? She had a long stay in the ICU and intubated. She arrives with a G tube and she also received IV antibiotics. Okay, so let's see. Some of you enhanced barrier and some of you put in contact. So let's see which one. So the answer is enhanced barrier precautions. And why would we use that? A lot of you, some of you put the answers and I appreciate it. This patient is now a resident in a skilled nursing facility. There's a presence of indwelling devices, right? She's got the G tube and she received long-term antibiotic therapy. All right, good job. We're gonna move on to our next case scenario. You're preparing to give your resident morning care, which includes a shower, dressing, transferring her to the chair, and changing the bed linens. And all of these, as we just reviewed, right? Those are all high contact resident care. But this patient has C. diff. She does not have any indwelling medical devices. And so the first question, should this resident be placed on precautions? Yes or no? I see a lot of quick answers. Excellent. So the answer, good job, guys. The answer is what? Yes, right. Good job. This patient should be put on precautions. And the next question, what precautions should the CNA use and why? Contact. I'm seeing a lot of good answers. Excellent. Okay, a lot of you put contact. Excellent job. And why? Yeah, okay, the answer is contact precautions. Excellent. Because this patient, right, she, with known or suspected infections caused by a pathogen can be passed by contact or placed on contact precautions. An example is C. diff. Patients are at high risk of contaminating their environment, such as this patient with fecal incontinence, so she should be placed on contact precautions. Great job. And we're going to go on to our last scenario. An 86-year-old patient is received by an accepting long-term care facility. He's coming from a local hospital where he had been there for 6 weeks recovering from hip fracture. He received intravenous antibiotics for a prolonged time. The antibiotics were completed before he discharged from the hospital, and he arrives to your facility with a PICC line and a Foley catheter. So here's the question. How should the long-term care facility prevent C. auris? So what can that facility do to prevent C. auris or the spread if this patient has it or could possibly have it? Put your answers in the chat. What are some ideas? Enhanced barrier precautions, private room. Yep, enhanced barrier precautions, isolate patient. Good job. All right, guys. So here we know, right, that you would, here are some other ideas. Encourage staff and visitors to practice good hand hygiene, frequent use of hand sanitizers. Cleaning and disinfecting surfaces throughout the facility is important because, as we reviewed today, C. auris can live on surfaces for several weeks. Assure that the staff uses the appropriate disinfectants. What about antibiotic stewardship? Ensure safe and appropriate antibiotic use is critical for effectively treating infections, preventing harm. What about questioning the MD? Does this patient still need the PICC line and catheter? All right, those are possible entries into the body. And communication with staff, right, that perform close, prolonged patient care to take proper precautions. So you guys did a really great job. I appreciate your participation in the scenarios and the poll questions. You all did great. So we're going to move on now to our key takeaways and wrap things up. Candida auris, as we reviewed today, it's a multi-drug resistant yeast that can cause serious infection. MDROs can spread easily between hospitalized and nursing home patients. Candida auris has become a concern to healthcare due to many challenging factors, which we went over all those today. And it can spread by direct touch and also through clinical care. Infection prevention is the best management of Candida auris. Okay, so just reminders, these are to go over the requirements to receive your certificate of training today. In order to receive your certificate of training, you must have completed the pre-session survey at the beginning. You stayed with me today through the webinar, participated in today's session, And then also need to complete a post-session survey. And the link for the post-session survey will be emailed to you tomorrow, December 12th. And that'll be available to December 18th at midnight. Once you complete the requirements, the certificate of training, once you completed those requirements, certificate of training will be emailed to you on December 21st in PDF format. For EMS and dental providers, this can be used towards 1 hour of continuing ed credit. So please be sure that if you are looking to receive CNE credit today, that you complete the post-session quiz that will be emailed to you tomorrow with the rest of your post-session documents. And also, you're going to be getting a copy of today's PowerPoint presentation. It'll be emailed to you sometime this afternoon. So you could also follow Project Firstline on social media. Follow us on Twitter, Facebook, Instagram, and LinkedIn. And here is the link. You can pre-register for upcoming live webinars. Also, you can connect with us by emailing us directly. And if you did not enter your email earlier in the chat box, please feel free to enter it now if you want to be added to our distribution list of upcoming trainings. And we have some really exciting future trainings coming up in 2024. Can't believe that's already around the corner. And here are the references used for today's presentation. So I invite you now to please take the 3-question poll on your screen. This helps us to improve future sessions and assess everyone's learning needs. On behalf of Project Firstline Rhode Island, we all wish you all a healthy and happy holiday season. We look forward to seeing you all again in 2024. And I really thank you again for joining me today.
Happy holidays, everyone.
Happy holidays. Stay well. Thank you very much.